This is Sean Wong with Safia Psychiatry. Today we'll be covering Psychopharmacology Part 2. Note, this video is for educational purposes only and does not constitute medical advice. In Part 1 we cover the basics, ADME, receptor occupancy, and the core principles that guide prescribing. Now we'll cover 4 more advanced concepts: genetic polymorphism, age-related pharmacologic changes, steady state, and high drug interactions. Genetic polymorphisms. Not all patients metabolize drugs equally. The CYP450 system has significant genetic variations. Take CYP2D6, one of the most important enzymes in psychopharmacology. Patients fall into 4 categories. Poor metabolizers have little to no enzyme activity. Drugs metabolized by CYP2D6 accumulate to toxic levels. Intermediate metabolizers have reduced activity. They may need lower doses. Extensive metabolizers have normal activity, and this is the baseline for standard dosing. Ultra-rapid metabolizers have enhanced enzyme activity, often due to gene duplications. Drugs are cleared so quickly that standard doses may be subtherapeutic. A clear example is atomoxetine. It's primarily metabolized by CYP2D6. In poor metabolizers, standard doses produce plasma levels up to 5 times higher than extensive metabolizers. These patients experience more side effects, such as insomnia, appetite suppression, cardiovascular effects, and urinary retention. In ultra-rapid metabolizers, standard doses may produce subtherapeutic levels, leading to apparent treatment failure despite good adherence. Recognize the pattern. Unexpected side effects at standard doses suggest a poor metabolizer. Repeated treatment failure despite adherence suggests an ultra-rapid metabolizer. Consider dose reduction, often targeting 50% of the standard dose for poor metabolizers, or switching to medications not dependent on CYP2D6, in this case perhaps guanfacine, for suspected ultra-rapid metabolizers. Age-related pharmacologic changes. Renal clearance declines with age. Creatinine may look normal because muscle mass has decreased, but the kidneys are filtering less efficiently. Drugs cleared renally, such as lithium, gabapentin, pregabalin, accumulate. Doses that were appropriate at age 50 become toxic at age 80. Hepatic metabolism also slows. Liver blood flow decreases with age. First-pass metabolism is reduced. Drugs like trazodone or quetiapine may have higher bioavailability and stronger effects in elderly patients. Body composition. Increased fat, decreased water, decreased albumin. Fat-soluble drugs like diazepam accumulate and have prolonged half-lives. Water-soluble drugs may have higher peak concentrations. Low albumin means more free active drug for highly protein-bound medications. This is where the start low and go slow comes in. In elderly patients, everything takes longer to reach steady state, to clear the drug, and to stabilize on new medications. Steady state. Steady state is when the amount of drug entering the body equals the amount leaving. It typically takes 5 half-lives to reach steady state, and this has critical clinical implications. Assessing efficacy. Don't judge whether a drug is working before steady state is reached. For fluoxetine with a half-life of 2 to 4 days and its active metabolite norfluoxetine lasting even longer, steady state takes nearly a month. For venlafaxine with a short half-life of about 5 hours, steady state is reached in roughly a day. The drug you choose determines how long you wait to assess response. Loading doses. For drugs with long half-lives, a loading dose can achieve therapeutic levels faster, but in psychiatry we rarely use loading doses. We accept that it takes time to reach steady state. High-risk drug interactions. Some interactions are minor, others are life-threatening. Here are 2 that every prescriber should know. Linezolid and SSRIs and SNRIs. Linezolid is an antibiotic used for MRSA infections, typically prescribed for 10 to 14 days, but it's also a weak, reversible monoamine oxidase inhibitor. When a patient on an SSRI or SNRI receives linezolid for a skin infection, the combination can precipitate serotonin syndrome, confusion, hyperthermia, and autonomic instability. This is a classic scenario. The psychiatrist isn't consulting when the antibiotic is prescribed, but the interaction is life-threatening. Fluvoxamine and clozapine. Fluvoxamine is a potent CYP1A2 inhibitor. Clozapine is metabolized almost entirely by CYP1A2. When combined, clozapine levels can increase 5 to 10-fold, leading to seizures, severe sedation, and hypotension. This combination requires massive dose reduction and careful monitoring with therapeutic drug level checks. Conversely, smoking induces CYP1A2, so smokers often require double the standard clozapine dose to achieve therapeutic levels. And there you have it. If you enjoyed this content, please like and subscribe, and I'll see you in the next one.